Good morning, students. Today's lecture is on hemolytic anemia 2. The learning outcomes of today's lecture are listed here. Today, I will be mainly discussing on G6PD deficiency, PNH, and autoimmune hemolytic anemias. Let me come to a hereditary form of hemolytic anemia known as G6PD deficiency. G6PD deficiency means glucose 6-phosphate dehydrogenase deficiency. It is an X-linked trait. It's a genetic condition. As you remember, we had classified hemolytic anemias into genetic and acquired. So one form of genetic anemia is G6PD deficiency. Here what happens is there is abnormalities in glutathione metabolism resulting from impaired enzyme function, which reduces the ability of red cells to protect themselves against oxidative injuries, which leads to hemolysis. G6PD deficiency is triggered by ingestion of food, drugs, as well as with infections. The main food which is responsible for triggering G6PD is flava beans. Drugs include primaquine and chloroquine. Infections include viral hepatitis and typhoid fever. G6PD deficiency in the Middle East is known as flavism. It is endemic in Mediterranean, Middle East, and parts of Africa where consumption of flava beans is prevalent. In this slide, you can see the pathogenesis of G6PD deficiency. As I have mentioned earlier, it's basically an abnormality in glutathione metabolism. So under normal conditions, glucose 6-phosphate gets converted to 6-phosphogluconate in presence of G6PD enzyme. At the same time, hydrogen peroxide gets converted to water. In the process, NADP is reduced to NADPH. So if there is deficiency of G6PD enzyme, glucose 6-phosphate will not get converted to 6-phosphogluconate. There is no production of NADPH and hydrogen peroxide will not get converted to water. So what happens is ultimately there is accumulation of hydrogen peroxide in the RBCs, which leads to oxidative stress. This oxidative stress is responsible for hemolytic anemia, which develops in G6PD deficiency. Hemoglobin in G6PD precipitates as Heinz bodies. They are nothing but globin chains which become denatured. They can be identified by doing supravital staining. Heinz bodies can damage the membrane sufficiently to cause intravascular hemolysis. As these inclusion-bearing red cells pass through the splenic sinusoids, macrophages will plug out the Heinz bodies. As a result, the membrane damage, RBCs will have a bite taken out of them. So there is formation of bite cells, which are classical of G6PD deficiency. A fluorescent spot test is used to identify G6PD deficiency. Fluorescent spot test identifies NADPH produced by G6PD under ultraviolet light. When the blood spot does not fluorescent, the test is positive. This slide is showing the peripheral smear of a case of G6PD deficiency. What you can see here are only the RBCs, and inside you can see the supravital staining. If you look at the RBCs, there is anisopoikilocytosis. We can find the presence of bite cells. Bite cells are pathognomic for G6PD deficiency. Inside you can see supravital staining for Heinz bodies. The second hereditary hemolytic anemia, which will be discussed today, is hereditary spherocytosis. It is an autosomal dominant condition. It is a genetic defect affecting spectrin and ankyrin. The deficiency of membrane cytoskeleton produces abnormality of lipid bilayer, leading to the loss of membrane fragment. This forces the cell to assume the smallest possible diameter for a given volume, namely a sphere. In the picture, you can see that there is basic defect in spectrin and ankyrin. So the lipid bilayer becomes unstable. This helps in losing the membrane fragments. Lipid membrane fragments are lost. So the remaining RBC will assume the shape of a sphere, which is nothing but a spherocyte. And this spherocyte is taken up by a macrophage and removed from the circulation. This is the flow chart showing the pathogenesis of a case of hereditary spherocytosis. In hereditary spherocytosis, there is primary membrane skeletal defect. That is, there is defect of spectrin and ankyrin. Because of defect in spectrin and ankyrin, you can see that the membrane becomes unstable. So there is membrane loss. This membrane loss will assume the RBC to take a shape which is nothing but sphere. There is splenic trapping and there is phagocytosis, which leads to extravascular hemolysis in a case of hereditary spherocytosis. In the peripheral smear, we can find the presence of spherocytes. Spherocytes are small hyperchromatic RBCs lacking central pallor. Hereditary spherocytosis can be seen in children as well as in adults. Hemolysis is extravascular and there is presence of jaundice, splenomegaly and glial stone formation. After splenectomy, the spherocytes will persist, but anemia will be corrected. The management of a case of hereditary spherocytosis is splenectomy. An osmotic fragility test can aid in the diagnosis of hereditary spherocytosis. In this test, the spherocytes will rupture in hypotonic solutions than inside the RBCs. This is due to increased permeability of the spherocyte membrane to salt and water, which enters the concentrated inner environment of the RBC, leading to its rupture. The next form of hemolytic anemia, which I will be discussing today, is paroxysmal nocturnal hemoglobinuria, PNH. It is a disease that results from acquired mutations in PIGA, an enzyme essential for the synthesis of membrane-associated proteins. In PNH, GPA-linked proteins are deficient. It is the only hemolytic anemia caused by an acquired genetic defect. Red cells deficient in GPA-linked factors are susceptible to lysis on injury by complement, which manifests as intravascular hemolysis. The hemolysis is paroxysmal and nocturnal only in 25% of cases. The tendency for red cells to lyse at night is explained by a slight decrease in blood pH during sleep, which increases the activity of the complement. PNH is diagnosed by flow cytometry. Here you can see the peripheral smear of hereditary spherocytosis. You can see RBCs, WBCs and platelets are not seen. There is anisopoikilocytosis. There are small RBCs which lack central pallor, which are nothing but spherocytes. The next form of hemolytic anemia is immunohemolytic anemia. These immunohemolytic anemias are caused by antibodies that bind to red cells, leading to its premature destruction. Some of them are caused by drugs. Antibodies which are normally present can be warm antibody, that is IgG, old agglutinin, IgM, cold hemolysin IgG. IgG antibodies are active at 37 degrees centigrade, hence they are known as warm antibodies. This is the most common type of antibody which is seen. It is seen in secondary conditions like SLE and drugs. Cold agglutinins are antibodies which are active below 37 degrees centigrade. They are seen in Mycoplasma pneumonia infections, infectious mononucleosis, HIV, Epstein-Barr virus infections, and cytomegalovirus infections. Cold hemolysins are IgG antibodies active below 37 degrees centigrade. They primarily occur in viral infections. A Coombs test is routinely done to identify these antibodies which are present in the cells as well as in the serum. Diagnosis of immunohemolytic anemia requires the detection of antibodies and complements on red cells. There are two types of Coombs test. One is a direct Coombs test and second is an indirect Coombs test. In direct Coombs test, patient cells are tested for surface antibodies, and in indirect Coombs test, patient serum is tested for antibodies. Other two types of hemolytic anemias are hemolytic anemia due to RBC trauma. This condition is seen in individuals using prosthetic heart valves. Mechanical heart valves, when they are implanted in the heart, when RBCs are passing through these heart valves, they undergo hemolysis. And the resultant anemia is a form of hemolytic anemia. Another form of hemolytic anemia is microangiopathic hemolytic anemia, caused by conditions like hemolytic uremic syndrome, DIC, SLE, and disseminated cancers. Here, we can find luminal narrowing, often due to deposition of fibrin and platelets. These vascular changes produce stress on the mechanically injured RBCs. Red cell fragments like schistocytes, Barr cells, helmet cells, and triangle cells are seen in the peripheral smear. These are the references, and if you are having any doubt, you can feel free and ask me at the end of this class. Thank you very much.